One very common procedure that we do in the ICU is called a bronchoalveolar lavage, or BAL. The BAL is not only diagnostic for us, but can actually also be therapeutic for our patients. This video is going to explain why we do BALs, how we do them, and who's involved with them, and what to look out for in your patients while you're doing it. The majority of patients that we're doing BALs in are patients who are on the ventilator and have a pneumonia. And when patients have a pneumonia, they produce a lot of purulent sputum that can plug off part of the airways, whether it's in the bronchioles or the bronchial tree, and maybe even as high up as the trachea and the endotracheal tube itself. And these mucus plugs can literally plug off the airway and reduce the ventilation that's happening to the lungs. One of the first things that we do for these patients is we use the inline suctioning. So most patients in the ICU, at least at my ICU, all of them will have inline flexible suction catheters, so we can go into the endotracheal tube and suction out anything that could be blocking the endotracheal tube or the trachea itself to hopefully stabilize the patient before we go in with a bronchoscope. Now, before I start the procedure, I always put the patient on 100% FiO2 through the ventilator. I will then have the respiratory therapist switch them to either a pressure or a volume controlled rate, so that as we increase sedation, we know that the ventilator will breathe for them. We will also have a nurse in the room who's monitoring the patient's sedation level, giving them pain medicines like fentanyl, using other sedating medications like propofol or Precedex. And the nurse will also be watching the hemodynamics. Patients can be hypertensive or hypotensive, and so having infusions in the room already that the nurse can titrate is very useful to either bring up the blood pressure or bring down the blood pressure so that it's stable throughout the entire procedure. Now, when we begin the procedure, there'll typically be an adapter that goes on the end of the endotracheal tube that allows our thin, flexible camera to go into the endotracheal tube. There will also be a screen on the whole bronchoscope cart where you can see exactly where your camera is. And so as you go through the endotracheal tube, the next thing you should see is the carina. Anterior rings, which are the tracheal rings that sit in the front of the trachea, will show you the top of the trachea, and then the back side of the trachea should be the longitudinal posterior membranes. And that way, when you're looking at the screen, you can differentiate the left side versus the right side of the lungs. Some patients in the ICU are so edematous and so swollen in the airway that it's difficult to make out what the anterior and posterior parts of the trachea are. So if you go down one of the lumens at the carina, the right upper lobe takeaway should be immediately after the carina, and that can confirm if you're on the right side for the lungs after the carina. As you go into that right upper lobe, you'll typically see what we call the Mercedes-Benz signs, where the right upper lobe sort of branches off into three smaller lobes, and that's another confirmatory way to say that we know we're in the right side of the lung. Now, the center of the bronchoscope has a channel that both allows you to inject fluid as well as suck that fluid out. And so once you get to an area where you see some mucus, you will then inject 10 to 20 cc's of saline through your camera and try and wash that fluid out, and then hold on to your suction as it basically pulls through your camera into the suction container. You don't want to suction too hard to the point where you see the airway start to collapse on itself. You can also, if you suction against a wall, start to see little marks of erosion where you're pulling against the friable tissue if patients are really sick. And so you want to avoid that. Most of the time, I'm able to break up some very purulent sputum by just tapping on the suction with my thumb, and that tapping of the suction can sometimes break it up so that it's not too thick to get through the channel. After you've cleaned up some of the proximal purulent sputum, you're then going to want to get into the deeper bronchioles close to the alveoli so that you can get a true BAL sample and hopefully sample something that will give you some information about what bacteria is growing in this pneumonia. I'll try and get into either the right middle lobe or the left lower lobe to get my sample. Before getting your sample, you have to let the respiratory therapist know that you're ready to get the sample, because then they'll attach a trap in your suction line, so that as you're suctioning out that sputum, that sputum will get caught into that trap, and then we'll be able to send that sample to the lab, which can then test it for bacteria. They are then able to test to see what antibiotics will work to treat it and if it's resistant to any antibiotics. Having this culture data allows us to narrow our antibiotic coverage, because typically if patients look like they're infectious in the ICU, we will start with what we call broad spectrum antibiotics. However, once we start to get resistance patterns on these bugs that are causing the pneumonia, we can then narrow our coverage so that we're not being too broad with our antibiotics. The reason you don't want to give everybody broad spectrum antibiotics is because as these bacteria are exposed to antibiotics, they develop what we call resistance to the antibiotic. Bacteria that develops resistance to antibiotics can be very difficult to treat. So not only will getting this sample allow you to tailor your antibiotics to the specific patient, you also clean out the airway and reduce a lot of the resistance to their airway, which should hopefully allow them to oxygenate and ventilate better on the ventilator.